Before we formally start this topic of echo, just what like up to I just want to just check it out. Uh, what what do you think? What is the significance of echo? Why you want to get echo?
I want to see the condition of the heart of the patient because anesthesia-related drugs they have effects on cardiovascular system. So I
Okay,
want to see the condition of the heart. It's
okay,
working properly, like ejection fraction, condition of the valves.
okay.
Uh,
Like what, for example, if you just in which patient would you like to have echo? Like which
uh, if the patient is having any comorbidities like hypertension, diabetes,
Mhm.
and things like this, and if he or she is above 40 year of age,
So for
so
that you need echo.
yes, mostly we prescribe echo in these patients above the age 40 or with any comorbidities.
Okay. Okay. So, for example, in that scenario, then we should have all we should do echo for all the patient coming for any surgery above age of 40. Am I right? Or this is one
Yes,
thing. Or another thing is that would you like to do echo for all the patient with hypertension?
yes, all the patient with hypertension.
No. The answer is
No.
no. The answer is big no. Okay.
Okay, if he or she is having controlled hypertension or uncontrolled hypertension, we will decide
Uh,
accordingly.
Uncontrolled hypertension will result in what? Will result okay, just for instance, thing is that the information, for example, the patient has normal echo, that then it
Mhm.
means that heart function is okay.
No.
Like for example, usually what is the first thing you see in echo of hypertensive patient?
Uh, Ejection fraction and
Okay,
hypertrophy of
what
the
is
heart.
okay, just a second, what is ejection fraction? Just try to answer. Just relax. I will
Yes,
make you understand that what is ejection fraction.
ejection fraction, stroke volume into मुझे exactly नाम नहीं आ रहा.
Okay,
I don't know
Mahajabeen,
exactly. हाँ,
would you like to tell what is ejection fraction?
Assalamu alaikum.
Walaikum assalam. What is ejection fraction?
Uh, it it is the fraction of blood that is pumped out of the heart, that out of the total volume that is present in the heart at that time.
Yes, like for example, what will be the volume? It will be the end diastolic volume
And systolic volume.
versus end systolic volume. Okay. So,
Yes.
for example, end diastolic volume was 100, and you the heart pumps 70 and remaining is 30. For example, this is 70% is ejection fraction. Okay.
Yes.
Now, Hadika, again, I give you a scenario. Now, there was some problem in the reception and heart receive only 70 ml. Okay. And now out of 70
okay.
ml, heart is pumping 60. So ejection fraction will be 80%. But does it mean the heart is good?
No, it means that it's working okay, but
No.
we don't say that it's
Yes. Tell me
perfectly
one
okay,
thing.
Haji.
If you go to some place, if they are not welcoming you, would you feel nice or bad?
What I feel? What's the
If
question?
you visit, if you visit some
Yeah,
place and you see that they are not welcoming you, so you will not feel good. Am I right?
yeah,
And
exactly.
for example, if you are going somewhere and they are very generous, they are giving you very nice reception, you feel easy. So this is the situation with a hypertensive heart. Okay, hypertensive, when there is
Okay.
hypertension, What is the effect of hypertension on heart? Heart has to pump against more systemic vascular
More
resistance.
resistance. Yes,
So
yes, yes.
gradually what is happening? There is a stiffness in the heart.
Oh,
There is
stiff,
left ventricular
left
hypertrophy.
ventricular hypertrophy. Yes, yes.
Hypertrophy. So what is the result in it? That heart is not still becoming generous. He's becoming very angry. So he's not it. The
Angry.
heart is not
Yes, yes.
relaxing. So when heart is not relaxing, this is the first sign that heart is getting angry. Okay. So what will happen? What is Frank's Starling law?
French Stalling law
I
is
don't.
that when there is more preload, the more blood comes in the heart, more is the stretch on the heart muscle, and then more powerfully the heart contracts to
Yes.
pump that blood out of the heart.
Okay. So this is the basic problem occurring in hypertensive patient because of gradual hypertrophy. The what sort of hypertrophy occurs in hypertension? There is one concentric hypertrophy and one eccentric hypertrophy. Can someone explain, Sumera? Because this question may be asked to you. So now if you know, please explain. What is difference between concentric and eccentric hypertrophy?
Sir, in a concentric hypertrophy, the muscles of the heart they grow inside, like towards the center,
Okay, like what
and
what you say, parallel?
in concentric hypertrophy, the size of the left ventricle will reduce in a diameter, and the muscle will grow inside, towards the inside of the heart.
Okay, like one
And
is in
in
series.
eccentric,
When they are growing in series, okay, they are lengthening. So this
okay,
is eccentric hypertrophy that occurs in dilated heart. Okay, and when they are occurring one by
okay,
one and chamber size is decreasing actually. Okay, so that
yes,
is
sir.
concentric. So usually in hypertension there is concentric hypertrophy. Okay, and then in dilated cardiomyopathy there is eccentric hypertrophy. Okay.
Okay, sir.
So, you see, this is when there is concentric hypertrophy, the heart relaxation is decrease. Okay. So now another theory which I actually asked. Can you just explain what happens during the in the cardiac cycle? That the same thing. If you want to explain in the cardiac cycle, how can you explain?
Sir, in case of hypertension,
Yes. Like for example, if there is a hypertensive heart, what will be the effect in the how it will change? Because I want to you to send this message that ejection fraction is the least important thing to be seen, which everyone the same which I made the title. Ejection fraction is normal, sir. So I want you to pull out of that thing that whenever we are looking at the echo, ejection fraction is the least
yes, sir.
important thing if it is normal. Yes, if it is not normal, it is the most important, it becomes the most important thing. But if it is written ejection fraction is more than 55%, it doesn't mean that heart is good. Okay. So that's what I want
Yes, sir.
you to understand. So how can you just have you heard, if you recall the echo report, there is written E over A ratio. E over A ratio. Have you got any idea about it?
No, sir.
Like for example, just before the mitral valve open, just before the mitral valve open, what's the phase of cardiac cycle is there?
Before the
Isovolumetric.
opening
Relaxation.
Please let the person who's answering give the answer, please. Okay. Yes, Sumera.
Sir, it will be isovolumetric relaxation.
Relaxation. Okay. So isovolumetric relaxation, you can compare it just for interest understanding. Sorry to interrupt you, Mr. Best Imadial. At the moment, we don't have any slide. Okay. If you don't understand anything, just let me know. I will explain to you again. Okay. Because we are not having any formal presentation at the moment. So I'm just explaining the thing. If you don't understand anything, just let me know. Okay. So just before the mitral valve open, there is isovolumetric relaxation. And actually, this is the most important thing to understand when you are understanding the diastolic heart failure. Okay. Because after isovolumetric relaxation, what happens? That mitral valve open and there is rapid filling from the
This rapid filling of the left ventricle from the
no,
left
left
atria
atrium.
and the left.
Yes, rapid filling occurs. Be a little loud. Rapid filling occur from left atrium to left ventricle. Okay.
Left ventricle.
So this early ejection which is occurring, it is E. Okay. Normally,
Okay.
it is the most the biggest fraction lies in that thing. Okay. And this is because heart is welcoming. So the blood is coming very easily from the left atrium to left ventricle. Okay. So what occurs when the heart becomes hypertrophic for any good reason, then this phase becomes lesser. And the last phase, which occurs in the form of atrial kick, which we label it as A, okay, or late filling,
Okay.
you can say, this becomes more and more significant. Okay, because the heart has to, left atrium has to push hard, or the importance of this filling becomes more important. Okay, so this is A. So this is E over A ratio. If you want me to write, I can. Just a second, please. Because I am not very good in these gadgets. I will try
Sir,
to
so
do.
we can say if EA ratio is decreases, so we can say there is left ventricular hypertrophy.
Yes. Just a second. Let me. I did not listen to you. Let me fix this thing. I'm trying to write it down. I don't know how to. Just a second, please. No. Okay. So E over A. Okay. So E or A we are discussing. So E is normal, E is more, A is low. Okay. So normally you can say it is 1.25. Because I'm not expert in it, I'm not a cardiologist. Okay. I'm just trying to explain to you. So this ratio, if it is more than 1, for example, it's normal because E is more and A is less. So gradually, if the A becoming more, so what will happen? It will becomes less. For example, it becomes 0.7. Okay. So this is what you will see in that's how they grade as diastolic failure. Okay. So it means that heart is not filling easily. The heart muscles are becoming stiff. Okay. They are getting angry and they are not letting the ventricle fill. Okay. Is it clear to you?
Yes, sir.
Uh, is it clear to you, Mahjabeen and who was talking before?
Yes, sir. Clear.
Okay.
Yes, sir.
So that's the important thing. And actually, in hypertensive patient, this finding is more important to you. Okay. So gradually, E over A ratio is disturbed, and the atrial kick. This is also important in valvular heart disease, like for example, this one mitral stenosis. Okay, in mitral stenosis, because the door is closed, so now there is restrictive movement going on. So it will have almost a similar effect. Okay, so this is the important thing you should be understanding. So now coming back to the thing from which we started, ejection fraction will decrease later on when the heart muscles gradually fail. Okay, so the sequence of event in hypertension in echo will be in the form of gradual hypertrophy, and you will be seeing it as change in EA or A ratio. Heart muscle, you can they can have the chamber size and the wall thickness. Okay, and generally they can see the contractility. That's what the people who are expert in echo, they can different appreciate. And actually, as an anesthetist, we should be looking at the answer of yes versus no. Okay, so that will be the thing which will be occurring later on, that when gradually, because of extending hypertrophy, and when there is hypertrophy, there are chances of ischemia. Okay, so now how ischemia will be seen? Who wants to tell how ischemia will be evident in echo?
Sir, in case of ischemia, there will be decreased wall motion abnormality,
Okay,
like hypokinesia,
it is called
akinesia.
as segmental wall motion abnormality. Okay,
Yes.
so if someone is doing T, that intraoperative T, it will be seen as segmental wall motion abnormality. Okay, and actually the contractility will be decreased when one like for example, if you are having a chorus song in which 15 people are singing together, if some area is silent, you will gradually, the sound will be going down. So similarly, similar fashion will occur here. So if there is an area of ischemia, it will be as initial finding will be segmental wall motion abnormality. Then leading to what will be the next step? Next step will be hypokinesia. Okay. So if you can recall any echo report, there is a mild apical hypokinesia. You will find a report like that. Okay. And that will be according to the area of supply of heart being involved. Okay. Okay, Sumera?
Okay.
So next step will be akinesia. If there is some area becomes dead, so it will be akinetic. So this will be the sequence of events: decrease diastolic relaxation, global segmental wall motion abnormality, hypokinesia, akinesia, and then this will occur. This will be resulting in decrease in ejection fraction now, and now decrease in ejection fraction will be significant. It means that heart is unable to pump significant amount. Okay, so that is the sequence of event in hypertension or heart failure, if you are talking about left-sided heart failure. Okay, so similar thing occur in, for example, valvular heart disease. Okay, so now we cover this portion as well. What you see in a valvular heart disease in echo report?
There can be a error.
Yes, please.
Sir, during valvular heart disease, we can see the diameter of the valves,
Mm-hmm.
then regurgitation from any valve.
Okay, anything else?
And again,
Stenosis,
EA
we can see the
ratio.
stenosis.
Just a second, please. Whosoever want to answer, just raise the hand. I will ask the question. Okay, who was answering? Please tell.
Sir, we can see the diameter of the valves,
Okay.
and then movement of the leaflets, and then we can see any regurgitation.
Okay. You are missing the
And
most important thing.
Valve area and the pressure gradient.
Pressure gradient. Okay. It is called
pressure
as
gradient.
transvalvular pressure gradient. Okay. So that is the most
Okay.
important thing if you are talking about valvular stenosis. Okay. So valve size will decrease, but still maybe it is fulfilling the requirement. Then when the pressure gradient increase, that's when problem is starting. Okay. And then this one, there will be stasis. So because of stasis, if, for example, if it is mitral stenosis, what can occur? There will be stasis of blood, and that will result in clot. Okay. So you can find left atrial clot, or another thing, there may be this one chamber dilatation of left atria as well. Okay. So
Okay,
gradually,
sir.
and regurgitation, how will you quantify? There is a word for regurgitation when you see in echo report.
Doppler study.
Be a little loud. I cannot hear you. Please say again, Dr. Amir.
Doppler. Pro Doppler study.
No, Doppler study is all the way. Okay, but
Yeah, to,
what you
to see the color of Doppler.
Jet area regurgitation.
regurgitation fraction. Okay,
Oh.
it's a
Area.
regurgitation fraction. Okay, so valvular regurgitation is labeled as 1+ or 2+, mild, moderate, or severe, according to the how much portion is going forward and how much is going back. Okay, if the more is going forward and less is going back, it is mild. If it is mid-bid, it is moderate. If it is more is going back than going forward, it is severe. Okay, so that's how you label it as like mild mitral regurgitation or aortic regurgitation, and like that. So now we are like we have covered the findings in hypertension, findings in failure. For example, if you just say about right ventricular failure, what will be the possible cause of right ventricular failure? The most common, if someone asks you what is the first thing which comes to your mind? Right ventricular failure. First thing.
Ischemic heart disease.
No. Ischemic heart disease, yes, but there is something even more common than that. Ischemic heart disease is left
Pulmonary
ventricular failure.
hypertension.
Valve stenosis.
Just a second.
Pulmonary hypertension.
No, Haifa.
Pulmonary
Yes, you are.
hypertension.
Just
Pulmonary
please.
hypertension.
Just a second, please. There is something else than pulmonary hypertension. What will be the reason of pulmonary hypertension? There is something acute. You know, please.
Pulmonary embolism.
Pulmonary embolism. Okay.
Yes.
Pulmonary hypertension will not occur acutely. This will be a chronic process.
About primary.
Okay. So right ventricular failure is occurring immediately. The first thing is pulmonary is embolism, whether air embolism, whether this one amniotic fluid embolism, thromboembolism. Okay. So right ventricular fail, right ventricle fail. Okay. So when right ventricle fail, the septum, the interventricular septum will be shifted to the other side, and it will not only will be decrease in cardiac output because no blood is going towards the lungs, it is also putting the pressure on the other side, so cardiac output will suddenly collapse. That's why whenever there is pulmonary embolism, there is sudden absence of cardiac output, and then tidal will go down. Dr. Ali Mumtaz, can you close your camera, please? Your camera is on. If you can close it, please. Okay. So this is, and then chronic, maybe anything, cor pulmonale, COPD, any cause of pulmonary hypertension can gradually lead to right ventricular failure. Okay, but if we are talking about anesthesia, this is the most important thing. So in echo, there will be shifting of the septum to the other opposite side. Okay, and then the same regard, you will measure the pulmonary artery pressures. Okay, okay, Haifa.
Yes, yes.
So
Exactly.
in pulmonary, so PA pressures will be important to you. Okay. So if, for example, this is another important thing in addition to what we have discussed up till now, the doors, the valve size, valves are opening, closing properly. There is no regurgitation. The transvalvular pressure gradients are okay. Heart is contracting nicely. The contractility, the chamber size, chamber clot, any dilatation. Okay, and then this is another important thing in echo, pulmonary pressures. Okay, so if you have high pulmonary artery pressures, so then you have to avoid all the factors which will further aggravate this. Okay, so you will be avoiding stress, you will be avoiding pain, you are giving multimodal analgesia, and you are handling it like that. Okay, and what will be the next step? If still, but Haifa, you will not answer because you know about it. What will be the
Yes.
next step of, if you want to be sure, if you are see that there is a increased pulmonary artery pressure and there is something you it will be actually it will be dependent on what the patient is, but in some patients, if you want to be sure what are the pulmonary artery pressures, what you do, what is the next step? Anyone knows? It's right heart catheterization. Okay, in that you see the exact dynamics, what we do in the cath lab. Okay,
Is it pulmonary wedge pressure?
no, not pulmonary wedge pressure. It is the, just like in the cath lab we do the pulmonary angiography, there is similarly they do the right heart catheterization. Okay, and they measure the pressures directly, and this is actually things which are being done in patient with cyanotic heart disease. Okay, and they are checking the reversibility element, and that's how they decide about the procedure they want to do, because there are complex congenital heart diseases in which there is pulmonary hypertension, there are mixing of blood in the all chambers of the heart. Okay, so in that condition they are doing the pulmonary right heart catheterization, and they are using nitric oxide as well to see the responsiveness. Okay, so that is the next step of pulmonary hypertension. They do a right heart catheterization. Okay,
May I added some point related to pulmonary measurement,
yes,
hypertension?
please.
Yeah,
Yes,
tricuspid regurg, acute tricuspid regurg in echo we can estimate it, especially in pulmonary embolism. If you have
yes,
tricuspid regurg not found before, it is indicated of something wrong with the vasculature of pulmonary.
yes, yes, you are absolutely right, because the pressure is coming back. Okay, so what else is left in echo? uh, can you decide about the management of a patient in ICU with shock on the basis of echo?
Yes, sir. On the basis of echo, we can assess the inferior vena cava diameter.
Okay,
So we can assess the fluid
diameter
status,
or compressibility?
compressibility.
The more important, the appropriate word is compressibility. If we have a patient with shock, hypotension, and now you see the superior this vena cava, the vena cava is compressible, so it means you can give some more fluid. Okay, and then you do the echo and you see the chamber, the heart is not contracting well, so it means that the cause is probably low cardiac contractility. So in that case you can give some inotrope. Okay, inotrope, like you can increase epinephrine. Okay, if you see the echo and you see that heart is the right ventricular septum is pushed towards the other side. So it means that there is right ventricle is not contracting very nicely. And you have this patient, you may consider to start milrinone, okay? Because milrinone or dobutamine are good. Milrinone is a better choice for right heart failure. So in these patients, we can use milrinone. But whenever milrinone, what is milrinone? Mahjabeen, what is milrinone?
I'm sorry, I don't know.
The
Okay,
phosphodiesterase inhibitor.
phosphodiesterase inhibitor. So what will be the effect of milrinone? It will increase the contractility of right ventricle, but it will cause vasodilatation. Okay, so it can cause hypotension itself. Similar is the problem with dobutamine, because dobutamine people use it, but it will cause the side effect of this thing is that it will cause vasodilatation and patient can even become hypotensive. Okay, so this is another finding which you can get from echo. So vena cava compressibility, right ventricular failure, chambers contractility, and what else? What else I can see?
Edema, pitting edema.
Pitting edema from echo, Dr. Humera.
Nice. Hepatic and not.
Okay, what else you can see from echo? Anything else?
The structure of great vessels like aortic dissection or something.
Yes, you can see these things as well. But like now we come to the conclusion. I would just let me show the screen, because usually this is the misconcept that we have to do echo in every patient. So actually it's not like that. Okay, so you can have a look on this. Okay, dyspnea of unknown origin. Dyspnea of unknown origin. Okay, somebody said in the start hypertensive patient. No, hypertension with end organ failure. End organ failure in the form of angina. For example, if there is angina class 1 or 2, or there is heart failure, okay, then you would like to do the, if there are more clinical risk factors, then you will be doing the echo. Okay, not every diabetic patient. Diabetic patient on insulin dependency. Okay, if you have a patient of insulin dependence, in that patient, if you have more like history of, we discussed before the clinical risk factor, can anyone repeat them? What are the intermediate predictor or this one clinical risk factor? Anyone wants to tell?
Risk factor about what?
Clinical risk factor,
So
intermediate predictors.
intermediate predictors includes the history of MI, mild angina,
Okay,
compensated cardiac failure,
very good.
diabetes mellitus, and renal impairment.
No, insulin dependent diabetes mellitus, angina
G.
class 1 and 2, or stable angina, you can say, or compensated heart failure, or New York Heart Association class 1 and 2. Okay, previous history of
Yes.
MI. Okay,
Okay.
so
Sorry, again, this is the risk factors, or because I missed the question.
yeah,
This is
actually,
scoring for something.
just a second. Actually, the thing is that in which patient would you like to have echo? Okay,
Okay.
would you like to do echo in every patient? No.
So
Okay.
we have some strong indication.
Yes, so that's we are discussing that if we have a, like, not every hypertensive patient you can see not indicated routine preoperative echocardiography. We do it. Repeat assessment of previous echocardiogram with no intervening change in clinical status. No. And another thing is that echo will change any management? then you will not do it. Okay, that's what actually this is the American Heart Association. I will just show you the just give me a second. I will also show you this screen. Just a second. This is actually European Society guidelines. Okay, so we have discussed this before as well. That first of all, we have to see the urgency of the surgery. If it is urgent, then you just have to optimize the management. Okay, urgent surgery or emergent surgery, you have to proceed. If no, then you are looking at the active cardiac conditions. Can someone tell active cardiac conditions? This is just a repetition. Sumaira,
Yes,
which
sir.
are
There
the
are 5 active cardiac conditions like unstable angina, class 3 and 4,
okay?
acute MRI, recent MI, and decompensated heart failure, class 3 and 4,
What
and
is
severe
acute MI?
arrhythmias.
Just what is acute
Acute
MI and what is
MI,
recent MI?
sir, in acute MI, if MI occurs within 1 week and MI more than 7 days but less than 1 month is recent MI.
Recent MI. So okay. So either acute or recent MI or
A decompensated heart failure,
like New
severe
York Heart
arrhythmias,
Association
class 3 and 4,
4. Okay. Those two. What else?
severe arrhythmias, severe valvular heart disease,
Okay. Just a second. Just slow down.
unstable
Slow down.
angina.
What are slow? What are significant arrhythmias?
Sir, like life-threatening arrhythmias like SVTs, conduction blocks,
Okay.
ventricular tachycardias.
Okay.
So then we can go for
You are missing bradycardias.
echocardiography.
Symptomatic bradycardias.
Yes.
Symptomatic bradycardias. SVT. Okay. Atrial fibrillation. Okay.
Okay, sir.
So significant arrhythmias, severe valvular heart disease. Okay. Tight
Yes, sir.
mitral stenosis, tight aortic stenosis. Okay. So
Okay.
these, whenever you are looking at any patient, you have to see that if you find any of these things, you will say this is active cardiac condition, and that will make it ASA4. Okay. That will make the condition like hypertensive patient is not ASA4. Uncontrolled hypertension is not ASA4. Even it is ASA3. It becomes ASA4 or active cardiac condition if the patient becomes having MI, if there is heart failure, if there is any significant arrhythmia because of ischemia. Okay. So that is how you will be interpreting the patient. So now if there is active cardiac condition, yes, then you will be doing what? You will be doing the cardiac evaluation, multidisciplinary team, and you will be evaluating the patient whether, for example, if patient needs angiography, you will go for angiography and do the angioplasty. Okay. If you do the angiography and you find that this patient needs CABG, you will do the CABG first because there is no urgent surgery. Am I right? Are you understanding? Have you ever seen this chart? That is how we have to do the evaluation. This thing should be in your mind. First question is urgent surgery. Okay. Then the second is unstable cardiac conditions or active cardiac conditions, or in different books, it will list them as major predictors. If it is no, if it is yes, I told you what you have to do. Okay. Sorry. If it is no, then what else? What will be the next step? You will be doing the surgical risk. Okay. You will be doing the surgical risk. If there is low surgical risk, what you will be doing? You will be doing ECG.
So revised cardiac index.
Revised cardiac risk index, yes. Okay. So are you getting? Like you will be after that, if you don't have active cardiac condition, you are actually considering 2 or 3 things. One of them is the functional class. You will be assessing the METs. If they are more than 4 METs or not more than four METs, and you are understanding the you are quantifying the surgical risk, whether it is a low risk surgery or intermediate risk surgery or high risk surgery. Okay. And then you will be doing here, you see, non-invasive testing. I will stop it because I am unable to make you understand. I will make you a simple rather than these complicated chart, because whenever we look at these complicated charts, sometimes we don't understand. I will explain to you. You will see that the patient is having any urgent surgery, you will proceed. If you see the patient does not have active any emergent surgery, what you will do, you will look at any active cardiac condition. If active cardiac condition is not there, you will consider 2 things. One is the functional class, and one the surgical risk. Okay. And third is clinical risk factors. You will see whether there is any clinical risk factor or no. Clinical risk factor we have just discussed: ischemic heart disease and history of CVA and insulin dependent diabetes mellitus. If there are more than one risk factors, in that condition you will plan echo, like here they have told resting echo and biomarkers for the evaluation of left ventricular dysfunction. So that's coming back to from where we started. Echo is not indicated in a patient unless there is a risk factor. In hypertensive patient, it is not an indication to do echo. Age is not at all an indication to do echo. If there is any I will just show you again the picture which we were seeing here. Yes. Okay. So now again, coming back to this thing that you will be doing if there is dyspnea of unknown origin. Yes.
Dr. Zishan, that chart, where is we can find that? This is very useful. Thank you for you. It in your Google Drive, that chart. Found it
Yes,
in
it
which
is.
part?
You can find anywhere. This is European guidelines for cardiac patient for non-cardiac surgery. Okay.
Okay.
I can share it to you. I will share. Okay. I will share the link in the YouTube. Okay.
Okay.
So these are the indications in which you will be doing echo. Otherwise, you will not do echo. Okay. If there are signs of failure, if you see the patient having pitting edema, sacral edema, capitations, you see the frank signs of failure, then you will be doing echo. Otherwise, you will not do. You see a hypertensive patient, blood pressure not controlled, it is not indication to do echo unless there is any clinical signs. Okay. There is one indication which is not written here. If you are having a patient who received chemotherapy, sometimes they do baseline echo to see any change later on. That is something else. Okay. But usually you don't need to do echo for because of age or because of any, you understand, Dr. Hadika, I started with you. Okay. So now you understand in which patient you will do echo.
Yes, sir.
Okay. So actually we are doing echo without any reason. Without any reason. Even we don't know what is the interpretation. Okay. So that's what I wanted to share with you, that when you see the echo report, these are the things which I was discussing with you. These are the same thing: hemodynamic instabilities and hypertension and left ventricular outflow. Yes, something I missed. What about pericardial effusion and cardiac tamponade? You can also find in echo. This will be an acute emergency, and mainly there will be some history in which if there is pericardial fluid and it is pressing the cavities, the result will be the same. Okay. It will cause the decrease. Sorry.
Diastolic dysfunction.
Yes, it will result in generalized patient will not be filling, and then There is one sign, Sumera, would you like to tell what is that sign which occurs in cardiac tamponade? There is a triad.
Um,
Anyone recall? Beck's triad. Do
So
you remember that?
collapsing pulse, weak pulses होती है, weak peripheral pulses, hypotension,
Okay.
Raised
and
JVP.
Yes, raised JVP, low sign of perfusion, and muffled heart sounds.
Muffle heart.
Okay. So this is Beck's triad, and it occurs in acute cardiac tamponade. Okay. So you have to remove the fluid, otherwise patient will die. Okay. It is just like you just press the neck of someone. So if the heart is supplying the blood to every part of the body, if you don't relieve it, then cardiac output will not be maintained. Okay, so in similar fashion, you approach. I will just recap in 1 minute and then we will finish. We started from ejection fraction. We discussed about finding in hypertension. We discussed about finding in failure. We discussed about finding in pulmonary embolism. We just see that how we interpret different findings in heart. Okay. We discuss about E over A ratio. We discuss about diastolic and systolic failure. You will interpret the echo report. Next time when you see the echo report, you will not be looking like you were used to do before. Okay. You will find any ischemic changes. You will find any chamber clot. You will see the contractility. And I will suggest you, whosoever has the chance to learn echo, please just learn echo I worked 2 years in cardiac anesthesia, and at that time when I was looking, I was able to have some idea, but after that I never saw it or like I did not learn formally, so I forget it. But Haifa, you can recall, I used to listen a lot from Dr. Arif Hussain, and
Yes,
Dr. Arif
you're right.
Hussain, because focused echo and ultrasound of the cardiothoracic system is actually revolutionizing the management, because you are not waiting
Yes.
for the Yes, you are not waiting for the
May, may,
cardiologist to do the echo. You are just putting the echo probe and you are finding the answers in yes or no. Okay. And your management is deciding, like you are not relying to do X-ray to see the pulmonary edema. You are putting the probe and you are seeing whether the patient is full or not, and if you combine it with lung ultrasound, you will find I'm not very expert in it. There are some lines, B lines or something which you will see in echo or ultrasound, that whether the patient is wet or dry. If patient is dry, you can give more fluid. If patient is wet, you will not give any fluid. You will go for inotrope or vasopressin. Okay. So I hope you understand some of the basic concepts, and we will continue our fight with our heart in next session. Okay. Thank you very much.
Dr. Zishan, may I ask,
Yes.
request something?
Yes, sure.
Yes. If possible, in the future, you will do lecture for basic principle of echo and Doppler, because this is one of the most important questions coming up in the exams. It will be appreciated
Physical
a lot.
principle. It is Doppler principle. Actually, I'm not very expert in it.
Hmm.
Okay. But the basic principle is the same Doppler principle, the sound waves coming towards or coming away. Okay. So there is decrease in the frequency. That's what I know. I am not very expert in it. I will try to learn. Okay. Okay, everybody. So thanks a lot for your presence.
With you.
I'm sorry. Yes, Haifa.
Thank you. I mean, in the future, if you consider also in the future when you discuss nerve block, and because in my practice I am away from this, and in
Don't
the
worry.
future if you
Don't worry. Just what the channel people say, stay online. Okay. And
yeah, sure. Thank you very
the
much. I
people who are
appreciate.
in the who are in the early year of residency, I will suggest you, please make your learning in this way. You discuss the thing, you find the reasoning, no, don't try to cram the words of books. Okay, I'm not
Discussion.
reproducing it from any book, believe me. Rather, I am one of the people who say that the worst thing to do in 2022 is to worship one single book reading concept. It's outdated. It was valid 100 years ago, but not now. Okay, so if you will remain hypnotized by the people around you, please read this book, please read that book, you will be in trouble. You don't know, I guarantee you that majority of the people don't understand these things till the time they come out of the books. If you will keep on reading one book, and specifically that disastrous book, you will not understand anything. So please get the resources right from the, like, you can open any YouTube video, you can open Google, and you will find the answers. Okay, so that is the best way of learning. Make your own notes. That will remain. And I suggest another thing to all of you, whosoever is listening to me, that you can make your audio records. Okay, that is, even if you are lazy to write them down, just record whatever you read. Just record it and save it on phone, and then listen it again when you are free. That will be your revision, as well as you will come to know what you know. That, for example, try to record after it and listen after 2 to 3 days, how many things you are still recalling. Okay, thank you very much. Bye bye.
Thank you.